Hi, I'm Dr. Sanday Okello. I'm a pediatric pulmonologist at the University of California, Los Angeles, and I'll be hosting today's webinar entitled, Does My Child Have Asthma and How Should It Be Treated? For today's topics, I'll review statistics in children related to asthma, the definition and biology of asthma, the symptoms and how we make the diagnosis of asthma. I'll review types and patterns of asthma that we see in children, and then I'll end with a discussion of how asthma is assessed and should be treated, focusing on the medications. So first, to give you a little background to review statistics of asthma in children. Asthma is the most common chronic disease in children, affecting about 10% of children in the United States. Over the last 30 years, asthma has become more and more common, although there's not a good explanation for this. In fact, there are over 7 million children in the United States who are impacted by asthma. It is also the most common cause of missing school, and at least 60% of children with asthma will miss at least one day of school due to asthma. And then there's significant financial costs, recent estimates suggesting $11 billion spent to treat children with asthma. If we look at other information we have about children with asthma, at least half will have had an asthma attack in the prior 12 months, so a very significant portion of children who are impacted. There are about 7 million doctor visits every year just to care for children with asthma. Unfortunately, this is reaching only about 60% of children with asthma, so there are many children who are not seeking their doctor regularly. And as we'll see later, this is an important part of controlling asthma and maintaining a healthy life. There are over 600,000 emergency department visits each year for children with asthma. This represents a very small percentage, 7% of children with asthma. So if your child has experienced an emergency department visit for asthma, your child's doctor and you should be paying particular attention since this is an unusual experience. There are over 150,000 children hospitalized each year due to asthma. This represents just 1% of children with asthma. And again, if your child has experienced this, your child warrants special attention because this is an unusual experience. And then unfortunately, there are children who do die from asthma. It's very rare, but all deaths are preventable with proper medication and attention from their physician. So that's a little review of statistics of asthma in children. Now let's move on to talk about the definition and biology of the disease. We can first start with just a brief review of anatomy. Here we have a picture of the lungs, which are made up primarily by the airways. And the airways start with our windpipe, which travels down into our chest and branches out into the left and right lungs. These airways or bronchi branch out further, just like the branches of a tree, into smaller airways. And the airways are where asthma is active. So, asthma is a chronic disorder of the airways. And it's characterized by variable and reoccurring symptoms. We'll talk about symptoms in a little bit. It's defined by airway obstruction, which you can think of as blockages that limit air from getting in and out of the lungs. It's also characterized by airway bronchospasm, which you can think of as airway tightening or narrowing of the airways. And airway inflammation, which you can think of as swelling and mucus in the airways. So again, asthma is a disease that impacts the airways and has variable and reoccurring symptoms and is characterized by obstruction of the airway, bronchospasm, and inflammation. So let's take a closer look at each of these elements. I have a picture of the airways, an airway cut open, and over here you can see a nice open airway. The airways are surrounded by muscle, which you see here. And when those muscles contract, as in an asthma attack, it tightens or narrows the airway. And you can see how much narrower the airway is here than over here, which has a nice open airway. For some of you who are familiar with asthma medicine, such as albuterol, it's getting these muscles to relax that is what the albuterol does. And so we call this airway bronchospasm or airway tightening. The next mechanism is airway inflammation. And you can see there's mucus filling in the airway here, which is not present over here. And so this swelling in mucus we refer to as inflammation. And so you can see between the airway inflammation filling up the airway and the airway bronchospasm tightening the airway, that these would result in blockages of the airway, making it difficult for air to come in and out, or what we call obstruction. And these are the processes that your doctor should be trying to identify in terms of understanding whether your child has asthma. Now let's take a closer look at the symptoms of asthma and how we put this all together to make a diagnosis. So there are classic symptoms from asthma, some of which you may already be familiar with. Probably the most common one is wheezing, which we describe as a high-pitched whistling sound that can be heard when a child or someone with asthma is breathing in and out. Patients may complain of shortness of breath or difficulty breathing, particularly during physical activity, but also during colds or under other conditions. People may complain of chest tightness or even chest pain. This often occurs during physical activity. And then cough is another common manifestation of asthma, and one that many people fail to recognize or understand, that in fact for a child with a chronic cough, asthma is the most likely explanation. So it's up to your doctor to identify or determine if your child is having any one of these symptoms to help make the diagnosis of asthma. There are many triggers for these symptoms, things that may result or induce coughing or wheezing or difficulty breathing in your child, and I've listed a number of them here. Infections such as the common cold and exercise are probably the most common and probably affect at least 80% of children with asthma. The nighttime seems to be a common trigger as well. Asthma classically gets worse at night. There's no clear explanation for it, but it is a common pattern among patients with asthma. And then there are other exposures that I've listed here: exposure to grass and trees, furry animals, cigarette smoke, cleaning solutions, even weather changes, and even stress. Any one of these may be a trigger for your child's asthma. They don't need to necessarily experience all of these triggers, but any one should raise the alarm that maybe asthma is the source of your child's problem. Now let's take a closer look at the definition. So this picture comes from the National Institutes of Health, which for the past 25 years has put out recommendations for physicians on how to diagnose and manage asthma. And here they present some criteria or explanations for how to diagnose asthma. There are really just three things that they ask a clinician should determine. First is, are episodic symptoms of airflow obstruction or airway hyperresponsiveness present? And we'll break this down into more understandable terms in just a minute. Is airflow obstruction at least partially reversible? And we'll look at some breathing tests that will help us determine that. And then third, are alternative diagnoses excluded? So these are the three elements that your child's physician should be going through to determine, does your child have asthma? The NIH, or National Institutes of Health guidelines, go on to say that the main way that your physician does this is through taking a detailed medical history. So sitting down and talking with you and your child to find out, are they experiencing symptoms of asthma? Are there common triggers for these symptoms? And do they meet the criteria that we just went through above? A physical exam, of course, is always important. And then last, using a specific breathing test called spirometry to demonstrate obstruction and assess reversibility. Again, we're going to look at this in more detail and more simpler terms so that they're more easily understood. So first, our first criterion in making the definition was episodic symptoms of airway obstruction or bronchospasm. You can think of it as episodic symptoms of airway blockage or tightening. So these are symptoms that arise due to airway blockages or airway tightening. And we looked at some of those earlier. In fact, you or your physician can go through a series of questions that will help determine if you're having episodic symptoms of airway blockage or tightening. And I'll go through those with you now. First, during the past 1 to 2 years, has your child had repeated episodes of coughing, wheezing, chest tightness, or trouble breathing? Does your child have coughing, wheezing, chest tightness, or trouble breathing when they play or exercise? In the last year, has your child missed school because of coughing, wheezing, chest tightness, or trouble breathing? In the past month, has your child had coughing, wheezing, chest tightness, or trouble breathing in the daytime? In the past month, have they had these symptoms at nighttime or with sleep? Have you ever been told by a doctor that your child has asthma? And lastly, have you ever been told by a doctor that your child has bronchitis? So if the answer to any one of these questions is yes, then you should strongly consider asthma as a diagnosis in your child. Now, these are the symptoms of airway blockage and tightening, which was one of the criteria for making a diagnosis of asthma. Let's look at the second one, which looks at determining if airway obstruction is present and if it's reversible. So how we do that is with a special breathing test called spirometry. And this is a test for airway obstruction and reversibility. This picture depicts a child who's doing a routine spirometry test. The child puts basically a tube in their mouth. They take a full deep breath in, and they blow out as long and hard as they can. And what we do with the spirometry is measure the amount of air that comes out during the breathing out procedure. Because of what this requires, we typically do this only for children 5 years of age and older. So now let's look at an example of what your doctor would see when your child performs a spirometry test. Here is a typical example of a report that I would see or another physician would see for a child who's done spirometry. There are a lot of numbers on here, so I'll focus down just on a few key elements. First, we'll focus on these first three measures. The first you will see is entitled the FVC, or the forced vital capacity. This is the total amount of air your child blows out from the beginning when they've finished breathing in to the end when they've finished breathing out. And so for this child, it's measured in liters, and it's 1.87 liters. The second measurement you'll see is called the FEV1, and that's the amount of air the child breathes out during the first second of doing the spirometry test. And for this child, that is 1.35 liters. And then the last term that you'll see here is the FEV1/FVC, or what we call the FEV1-FVC ratio. In plain English, this is saying out of all the air that you exhale, the FVC, what percentage comes out during the first second, or the FEV1. And basically, if our airways are not blocked, we should be able to blow out 80% of all our air during the very first second of blowing out. And if we can't reach that 80% number, then that suggests there's a blockage of the airway, or what we call obstruction. And so you see for this patient, their FEV1-FVC is 72%. And so that suggests that this patient has obstruction or blockage of the airway. So now we've met the first part of this definition, airway obstruction. Now let's see how we define reversibility. So after the patient performs the first spirometry test, they're given albuterol and asked to repeat it. And we look at one specific measure, the FEV1, to see how much it changes. For this child, it goes from 1.35 liters to 1.90 liters. That's a 40% increase. Anything above a 10% increase would be defined as reversibility. So this indicates that the patient's obstruction can be treated with albuterol, for example. And so that's an important distinction to determine if your child has asthma. Now, there are other things for the physician to think about, and this was the third criterion after episodic symptoms of obstruction and airway tightening, and after obstruction that's reversible. The third definition was making sure that there are not other diagnoses other than asthma present. Most of these are uncommon, if not rare, but ones that your physician should think about, particularly if your child is not responding to typical asthma treatment. They include foreign objects that may end up in the airway, such as food. They include soft, floppy airways, which we refer to as tracheomalacia and even bronchomalacia, which affects the lower airways. Some children are born with blood vessels that wrap around the airways and can constrict them, and that may result in wheezing. There are a number of children who are born early and premature who may have symptoms similar to asthma. And then more rarely, children with cystic fibrosis, heart failure, and even masses in the chest. So all of these are considerations for your physician when they're determining whether your child has asthma or not. So now that we've reviewed the definition, let's go on and talk about types and patterns of asthma. So your child may have asthma and may have a different experience from other children with asthma. Here are some common types that we see. Most commonly are those triggered by head and chest colds, just the common virus. If you have a child with asthma who's under 5 years of age, it's highly likely that this is the type of asthma that they have. When they have a cold, they have coughing or wheezing, but when they don't have a cold, they're entirely fine. Second type is there are people whose asthma is triggered only by exercise. They have no problems with colds or at other times, but when they exercise, they experience chest tightening, chest pain, coughing, and even wheezing. This is probably more common in the older school-age student, middle school and high school. A lot of athletes may have exercise-induced asthma. Third type, which your child may have, is where coughing is the only manifestation of the asthma. People refer to this as cough variant asthma. The child does not have wheezing, but they do have coughing under the same circumstances that other children may have wheezing, such as with colds or with exercise and so on. There are then those children who have more persistent form of asthma, meaning they have symptoms under a variety of conditions, not just one. They have symptoms with cold, they have symptoms with exercise, they have symptoms with weather changes and so on. And then last, some children have more of an allergic manifestation of asthma. These are children who have other allergic conditions as well, such as eczema, environmental or even food allergies. So your child may fall into one or more of these types of asthma. Now, if we look at these types, we notice that there are certain patterns over time. Many parents want to know how long their child will have asthma. Well, it depends on what type of asthma they may have. So let me show you a graph of a few of these types. So along the bottom of this graph is starting from 0 years of age to 6 and 11 years of age. The first type we see is a cold-related type of asthma, which is very common in the preschool age group. And you can see as time goes on, there are more and more children who will develop this type of asthma. But then you can see by the time they reach 6 years of age, many children will have stopped experiencing this type of asthma. Probably 70 to 80% of children with this type of asthma will stop having problems by 6 years of age. A second type is allergic asthma. And as you can see from the graph, as time goes on, it becomes more and more common that more and more children develop that type of asthma. And that continues beyond 6 years of age. And these are children who are less likely to stop having asthma. And then a third type is what's called non-allergic. It's not the cold virus-related asthma. It's not the allergic asthma, but it is still asthma. And that tends to develop in the preschool age group and can peak around 4 to 6 years of age and then gradually declines and becomes far less common by the time those children are 11. So depending on what type of asthma your child has, we can make an estimate for how long your child is likely to have asthma. Now, let's focus on the assessment and treatment of asthma. So we'll assume that your child has already been diagnosed with asthma. Now let's talk about what to expect when you go see the doctor, what should happen, and how your child's asthma should be treated. So what should be assessed when your child goes to the doctor for an asthma visit? There are a series of items that we'll go through that are recommended to do a thorough assessment for children with asthma. First, there should be an assessment of how frequent your child is having symptoms during the day. Are they having wakening or sleep disruption at night? Are they using albuterol or a quick reliever medicine to relieve or control their symptoms, and how often are they using it? Is asthma interfering with their normal activities? Can your child go to the park and play? Can your child play at recess without any problems? Or are they actually having problems? Can they play in sports with problems or without problems? Is your child experiencing asthma attacks? Are you having to take your child to the urgent care or to the emergency department because of a severe asthma attack? Has your child ended up in the hospital due to asthma? And lastly, has your child required oral steroids to control their asthma? And we'll talk about oral steroids in a little bit. But this is the list of items that your child's physician should be going through it every time they see your child in the office to determine how well your child's asthma is doing or not doing. Now, there are ways to make this process easier both for you and your physician, and one of those ways is to complete an asthma questionnaire that'll guide you through these types of questions. So let me take you through an example now. Here's a questionnaire that I use for my patients with asthma. It consists of 11 questions. When you come to the office, you would receive this, and at the top you'd fill in your child's name and then the date. And at the top it says, please check one answer for each of the following questions. Your answers will help your doctor give you the best asthma care. Now let's go through the series of questions that you would fill out. The first question, since your child's last visit to the doctor, how has your child's asthma been? If your child has not seen a doctor, please answer about the last 2 months. And so you can say that your child's asthma is getting better, that it's staying the same, or getting worse. The next question, since your child's last visit to the doctor, how much have you been bothered by your child's asthma? If your child has not seen a doctor, please answer about the past 2 months. And you can say you're not bothered at all, that you're somewhat bothered by your child's asthma, or that you're very bothered by your child's asthma. The next 3 questions ask about indicators of asthma attacks. Since your child's last visit to the doctor, has your child been to the emergency room for asthma? You can say no or yes. Have they been hospitalized for asthma? No or yes. And have they had to use prednisone for asthma? And again, you can say no or yes. The 6th question asks about your child's regular asthma medicines. It asks, how often do you forget your child's daily asthma medicine when he or she feels fine? And you can say, I'm not supposed to take a daily asthma medicine, or that you forget none of the time, some of the time, most of the time, or all of the time. And then the second and final page of the questionnaire has these 5 questions, which get more at the symptoms of asthma. So the first question says, over the past week, how many days has your child had asthma symptoms? For example, cough, chest tightness, shortness of breath, and so on. And you can say it's been 0 days out of the past week, 1 to 2 days, 3 to 6 days, every day but not all day long, or every day all day long. The next question asks, over the past week, how many days have you had to give your child medicine to quickly relieve asthma symptoms, such as the albuterol, the inhaler, spray, or pump? And again, it's the same options as above. 0 days out of the past week, 1 to 2 days, 3 to 6 days, every day not all day long, or every day all day long. The next question, over the past week, how many days did your child have an asthma attack? For example, when it's harder for your child to breathe, when you give your child more asthma medicine, or when the asthma medicine does not work. And you can say 0 days out of the past week, 1 day, 2 to 3 days, or 4 to 7 days out of the past week. In terms of activity limitation over the past week, how much has asthma limited your child's activity? You can respond not at all, slightly, moderately, very much, or completely. And then the last question, in terms of nighttime symptoms, how many nights did your child's asthma keep your child from sleeping or wake him or her up in the past 2 weeks? And you can say 0 nights, 1 night, 2 nights, 3 to 7 nights, or 8 to 14 nights. And so these last 5 questions, your physician will look at them all together and then determine how well controlled your child's asthma is. There are 4 categories here on the bottom, going from best to worst. So let me show an example of how this would work. Okay? So if a patient came in and said that their child's asthma, they were having daytime symptoms every day, all day long, that they used a reliever 3 to 6 days out of the past week, that they had 2 to 3 days of asthma attacks, they had no activity limitation, and they had 2 nights of sleep disruption, their asthma would be classified as severe persistent, since that's the most severely reported symptom. Now, the goal for all children with asthma is to be over here in the mild intermittent category or in the green box. And that's regardless of whether your child is on an asthma medicine or off an asthma medicine. And so every time you go to see your doctor, he or she should be making a determination, is your child's asthma controlled, or is it one of these other categories that suggests the asthma is not controlled? And so if the asthma is not controlled, then you need to be seeing the doctor more frequently. If it is controlled, then you have more time between visits. So that's the assessment process. So just to recap, you should be seeing your doctor at least every 6 months for an asthma evaluation. If you're having problems, in other words, if your asthma is not controlled, such as based on that questionnaire, you should be seeing your doctor every 2 to 6 weeks. Ideally, you would complete an asthma questionnaire at every doctor visit. It will help you and your doctor best understand how well your child's asthma is at that time. And then ideally, they should have breathing tests or spirometry performed at least once a year for your child that's 5 years of age and older. And so that is the assessment that would occur for your child going to see the doctor. Now let's focus more on what medications are available to treat your child's asthma. Here's a poster of a variety of different asthma medications. I won't go through all of them, but I'll focus on a couple of categories. Overall, there are about 4 categories of asthma medicines that we'll talk about today. The first category are the short-acting bronchodilators. In other words, these are medicines that help the airway open up. At the beginning of the webinar, we looked at a slide of the lung where the muscles had contracted and narrowed the airway down. These medicines help those muscles to relax and have the airway open up. You may recognize one of these inhalers here that your child uses. Here, all of these medications basically use the drug albuterol. Typically, these medications are used only when your child is having symptoms such as coughing or chest tightness. You can take anywhere from 2 to 6 puffs of these medications, and ideally this is taken 4 times a day while your child is having symptoms. Many patients that we see do not use these medications actually enough when their child is experiencing symptoms. Since these medicines last 3 to 6 hours, for a full day it would be necessary to use them approximately 4 times. However, these medications do not treat inflammation. So in the slide we looked at earlier where there was mucus and swelling in the airway, these particular medications will have no impact on that. And so these are not good preventative medications. Ideally, if your child's asthma is well controlled, 1 inhaler should last 6 to 12 months. So if your child is going through 3 or 4 or 5 inhalers in a year, that probably is a sign that additional medicine is needed to better control your child's asthma. So again, the first class of medications that we're reviewing are these short-acting bronchodilators, which are basically albuterol, which help the airways to relax and open up. For all of these inhalers, we should use devices called spacers, okay? The inhaler attaches to one end of the spacer, and when you squeeze the medication, it allows your child to breathe the medication more effectively into their airways. And this reduces the risk for side effects. There are some of these albuterol medications that can be used in what we call a nebulizer, where you pour the medicine into this cup and it creates a mist that the child breathes in. So you may be familiar with either of these medications that I've listed here. Now, for all children who take a nebulized form of the medication, they should either use a mouthpiece or a face mask. And again, this is for most effective delivery of the medication to the lungs. Now let's talk about a second class of asthma medications. These are what you see listed here as inhaled corticosteroids. These are typically used every day, whether your child is having symptoms or not. A typical dosing regimen is 2 puffs twice a day. And these do treat inflammation. So that mucus and swelling that we saw earlier, these reduce that mucus and swelling. And so this is why they're used daily. and typically used daily for at least 3 months, but depending on the patient, may be used for longer periods, even a number of years. Now, when your child is doing well, so when they've completed a survey such as the one that I showed you earlier, and their child's asthma shows up on the survey as well controlled, then it can be time for your pediatrician to decrease or even stop the asthma medication if your child's asthma has been well controlled for at least 3 months. So again, a second class of medication are the inhaled steroids. These do treat inflammation. These are used on a daily basis. And when your child has been doing well for at least 3 months, they can be decreased or stopped. There are nebulized steroids as well. Budesonide is listed here, again using the same type of nebulizer, and again should only be administered using either a face mask or a mouthpiece. The third class of medications I'll talk with you about is Montelukast, or you may be familiar with it as Singulair. These are different forms that it comes in, some sprinkles in a packet that you can sprinkle over applesauce or other types of food. And then there are three other tablets, 4 milligrams, 5 milligrams, and 10 milligrams, which are dependent on the age of your child rather than weight or severity. These medications are anti-inflammatory, but they are not steroids. So again, they'll reduce that mucus and swelling that we saw earlier in the airway. Therefore, they're taken on a daily basis. These are typically taken once a day. Again, at least for at least 3 months, but depending on the patient, can be taken for longer periods of time. And as with the inhaled steroids, when your child has been doing well for at least 3 months, then these medications can be stopped. Okay? And then oral steroids are the fourth and last category of asthma medicines that I'll talk with you about today. Oral steroids are very intensive, strong anti-inflammatory medications that are used typically for people who are experiencing an asthma attack or for the rare patients who have very severe asthma. And I've listed different formulations. Most commonly it comes in liquid, but there are pill forms available as well. These are typically taken for 3 to 10 days and then stopped. So they're typically not intended to be used for months or even years on end. They're typically far too strong for that type of use. We dose these according to weight, and a typical dosing is 1 milligram per pound in weight of your child. So if your child weighs 25 pounds, for example, they would get 25 milligrams of prednisone each day for 3 to 10 days. So this is the last category that I will discuss as far as medications. Of course, many parents are worried about side effects of any of these medications, so I'll go through that briefly with you. Albuterol, the first medication we reviewed, commonly has a number of side effects, including an increased heart rate, jitteriness, and even hyperactivity. At least half of children who take this medication will experience one of these. These side effects do tend to decrease over time, so that the more times your child has taken albuterol, the less likely they are to experience these symptoms. Certain techniques, such as using a spacer, will decrease the likelihood that they experience any of these side effects. In terms of inhaled steroids, so the second category of medicines that we looked at, it has been documented that some children will experience a slowing of their growth rate, and that for children who are on this for extended years at a time may experience up to 1/2 inch reduction of their final adult height. There is also the possibility that children may develop thrush or a white plaque in their mouth. Again, both of these side effects are uncommon, if not rare. In terms of the third classification of medicine, the Montelukast, some children may experience nightmares or even depression. Depression is typically seen in older children, but can be seen in younger children as well. And again, these are rare. The last class are the oral steroids, on which you can see mood swings, both kids who are more euphoric and happy, as well as kids who may become more angry and aggressive. You may see an increase in appetite, and it may be disruptive to sleep. These side effects are fairly common, so we do counsel parents about the possibility of experiencing these side effects. So this is just a recap of the side effects of the asthma medicines. So Just to recap in terms of treatment, you should receive proper training on how to take your asthma medicines. Your physician should provide you with a written treatment plan, or what you may know as an asthma action plan, that explains when to take your asthma medicines, how to avoid having an asthma attack, when and how to seek care when you're having asthma symptoms. And you should receive that at each visit. So in summary, I'll wrap up and recap what we talked about today. So first is that asthma is an airway disease of inflammation primarily that involves swelling and mucus of the airways. It also involves bronchospasm, which you can think of as airway tightening, and then obstruction, which you can think of blockages of the airway. We make the diagnosis of asthma based on determining whether you're having episodes of coughing, wheezing, shortness of breath, and/or chest pain or tightness. And that we also use lung function testing in children 5 years of age or older, or what we call spirometry. Recall that there are different types of asthma: cold-induced, exercise-induced, cough variant, persistent, and allergic. And that with those different types of asthma, that may determine how long your child has asthma. It's recommended that you see your doctor, or that your child see their doctor every 6 months at least for an asthma checkup, more frequently if their asthma is not controlled. And at that checkup, they should receive a written treatment plan or an asthma action plan. And then ideally, you utilize an asthma questionnaire to best or most accurately determine how well your child's asthma is controlled. And then last, we talked both about anti-inflammation and airway dilator medications that are available to control your child's asthma. So I will wrap up here, and now we have time for questions. All right, I'll read off each question to you. The first one, Teen MD asks, if you have asthma, should you also do allergy testing to look for allergic triggers? So this is a good question. About 75% of children with asthma will be allergic to something in their environment. So it is helpful to understand what is in their environment that may be a trigger for their asthma. So the answer to your question is yes, you should also have allergy testing done. The second question that I received, when should a primary care physician make a referral to see a specialist? Well, this is a good question, and there are different answers to that question. Probably the simplest way to think about it is if your child is continually not doing well with asthma. In other words, your child is continuing to experience symptoms despite what you and your child's doctor have agreed upon for a treatment plan. If that treatment plan is not working, then it's worth seeing a specialist. A specialist can offer more time and more testing to focus on what may be a more complicated situation of asthma. The third question I received, have any studies revealed a connection between asthma and Tourette syndrome or OCD? I'm not aware of any connection between asthma and Tourette syndrome or OCD. What we do experience, however, are some children who are referred to us for asthma who have what we call a habit cough, which can be a tick-like syndrome. But that is separate from asthma, and that's not related to asthma. So I'm not aware of any connection between asthma and Tourette's. So moving on with the next question. This viewer says, I have kids and want to quit smoking, but I feel like I've tried everything. What are some things I can do? Well, I think this is a great question and one that we encounter commonly. There are a number of parents of children with asthma who do smoke. There are a few resources that we refer parents to. There are 1-800-QUIT lines. On the telephone, you can call and speak with a smoking cessation counselor who can go through a variety of options with you. So for example, if you call 1-800-QUIT-NOW, That's one of these 800 numbers that you can call to get help. A second strategy is actually to talk with your own physician. There are a number of medications that are out there that are very effective in helping you to quit smoking. Wellbutrin is one. There are others that are out there. And some people require more than just one medication. They may require 2 medications together. And then lastly, don't get on yourself if you've slipped up and started smoking again. The main point is to get back to trying to quit. Okay. The next question, it says, how does air pollution in Los Angeles impact the statistics of children with asthma? Well, this is a good question. And it seems like if you live close to freeways, within 500 feet of a freeway, then that really is the most likely thing to have a direct impact on your child's asthma. So in terms of thinking about strategies you can utilize, thinking about your proximity to the freeway. Now, it's a little harder for me to say in general in Los Angeles. There's certainly other cities with much higher prevalence rates of asthma, meaning there are a higher percentage of children with asthma. So if you look at the Bronx, for example, where they've reported that 30% of children there have asthma, whereas in LA it really does hover around the national average of 10%. So that may be a recent phenomenon as air might have gotten better in Los Angeles. But it certainly doesn't appear that there are higher rates of asthma in Los Angeles than other cities. Okay, moving on to the next question. You said 60% of kids grow out of asthma. How can you tell when they are no longer asthmatic at what age? And I think this is a great question. So this is getting a little bit more into the subtleties of how you manage a child with asthma. But let's say I'm seeing your child and we determine that your child has asthma and we've started a medication and your child responds very well to the medication. In fact, they go 3 months and I've seen them a few times over that 3-month period, and every time you fill out that questionnaire, your child's asthma falls into the well-controlled category. They're not having any problems. Then we sit down and talk and say, hey, why don't we see how your child does off of medication? And we decrease or stop the medication, and then observe how your child does over the subsequent 2 to 3 months. And if your child has no problems over those 2 to 3 months, then we extend the period of time where your child is not on any medication. And the longer they go off medication without having problems, the more confidence you and I can both have that the asthma has resolved. So I hope that makes sense. There's some children for which this works and they're able to stay off the asthma medication. There are other children for whom it does not work and we have to put them back on medication. But that would be the process for determining how that works. The next question, it says, how often are the symptoms of asthma mistaken for other diseases? Well, not very often. It's actually, the more common scenario is the other way around, where other diseases are mistakenly diagnosed when in actuality it's asthma. There are 2 common examples that I encounter. One is patients who come in or parents who bring their child in to say, oh, my child has bronchitis. And many times, if not all the time, those children get better with asthma treatment. Another scenario that I see commonly, parents may bring their child in and say, oh, my child has had pneumonia 3 or 4 times. Again, many times those are children with asthma. So it's rare that asthma is mistakenly made as the diagnosis. It's unfortunately not made often enough as the diagnosis. The next question the viewer sends in, I've heard a lot about a link between acetaminophen or Tylenol and asthma. What is the relationship between them? This is a great question. Around the world, not just in the United States, people have observed what seems to be an association between more frequent use of Tylenol and asthma being more common. However, these are studies that have gone back to look and are what we call a retrospective or a backward look in time. And so that is a decent level of evidence to prove this association, but it's not the best level of evidence to prove this association. So what people are doing now are studies where they look forward, where they follow people from a certain point in time forward, and then see if those children are more likely to develop asthma. I think it's probably too early to recommend that any parent not give their child Tylenol. But this is a great question and something that we should keep our eyes and ears open to in the near future. Another viewer asks, are there certain sports that are better for children with asthma? Not really. I think all sports are good for children with asthma. I encourage all of my patients to participate fully in any sport in which they're interested. So it doesn't matter if it's swimming or track or soccer or tennis or running. They should be able to participate in all of them. And that is certainly one of the goals of treatment, or one of the indicators of successful treatment, is that your child is able to participate in any sport that they're interested in. Next, it says, why are obese children at greater risk for asthma? This is a very interesting question. It does seem like there is an association between being obese and more likely to have asthma or even have worse asthma. There seems to still be a lot to learn about obesity, but one of the things that seem to be coming out about obesity is that being obese stimulates the inflammation in your body. And as we talked about, asthma is also a disease of inflammation. So it may be that the obesity is stimulating inflammation that also is triggering asthma. This still needs to be worked out, but this was an interesting question. Another reader or viewer, asks, can exposing a child to germs prevent asthma? Well, not that we know of. This certainly was a popular theory in the recent past. That children exposed to bacteria or fungus may have lower rates of asthma. But there's certainly no evidence that we should make this as a recommendation to parents to consciously expose their child to germs in order to prevent the development of asthma. Okay, next, another viewer asks, are there early warning signs of an asthma attack in children? That's, I think, an excellent question. And the early signs are the development of any of the symptoms that we talked about. Coughing, wheezing, shortness of breath. There are some others that I didn't list. Decreased stamina. The development of any one of these may actually be an early sign of asthma. And for those parents whose children have cold-induced asthma, even developing a cold itself may be the early sign of asthma. So they're parents with those types of children who I recommend at the first sign of a cold that they start giving the albuterol even if the child is not coughing or wheezing, because we know 1 or 2 days after they start developing cold symptoms, they will start having coughing or wheezing. And then the last question that I've received, it says, any suggestions of how to establish a good treatment routine for my child's asthma treatments? And I think this is another great question, and actually is probably one of the most challenging parts of treating asthma. Developing a routine that the patients and the family can follow consistently, because without consistent use of the medications, we won't get the optimal or desired results from those medications. So there are a few strategies that I try and use with the families that I take care of. One strategy is trying to link taking the medicine to another behavior that the family does. So for example, if everyone sits down to have breakfast together, let's use that one time to take the asthma medicine. If everyone sits down for breakfast together, let's use that as a second time to take the asthma medicine. If you drive your children to school, maybe taking the medicine in the car. I do encourage parents to be actively involved in the taking or the administration of the medication for their child, really regardless of how old the child is. I encourage parents to directly observe the child taking the medicine. The parent doesn't have to administer it, but they have to observe the child taking the medicine. Another strategy which you might find helpful is trying to simplify the regimen. So talk to your doctor about, are there options to take the medications once a day? And certainly we know for everyone, myself included, taking medication once a day is far easier to remember than taking it twice a day. So these are a couple of the strategies. Last, you can try setting a reminder on your cell phone about when the medicine should be taken. So those are all of the questions that I've received. I thank all of you for attending this webinar. The webinar will be available online, and I'm certainly happy to take emails. My email address was posted at the beginning of the presentation, and so you can access it again through viewing the webinar. It is SOKELO@mednet, mednet.ucla.edu, and I'd be happy to answer any further questions. Thank you again for your time.